Welcome to episode 217, Essential Elements of Ketamine in Mental Health Care, featuring Dr. Abid Nazeer, Fellow of the American Society of Addiction Medicine. Make sure to subscribe to be alerted about future episodes. By Clearly Clinical. Learn, grow, shine. Hello to our listeners. My name is Beth Irias, and I am really looking forward to a conversation today about using ketamine in mental health treatment. I'm delighted to introduce you to Dr. Abid Nazeer. One of his specializations is really not only understanding the role of ketamine in the mental health care continuum, but also how to effectively provide integrated care to patients who are interested in this. Thank you so much for joining us today, Dr. Nazeer.
Thank you. I'm happy to be here. I always love an opportunity to kind of help try to clarify and educate on ketamine in mental health.
Fantastic. Thank you for joining us. Dr. Nazeer is a board certified psychiatrist and also board certified in addiction medicine. And he has been working on setting up ketamine clinics. And I'm just so interested in learning more about this topic. I think many therapists hear about it, but don't know much about the use of ketamine in mental health care. Before we dive into the topic, why don't you tell our listeners a bit more about yourself and your background, and then how you came to do this kind of work?
Sure. So, by training, I'm a psychiatrist. Also have board certification in addiction medicine. So that's my secondary board. I did my training at LSU, Louisiana State University in Shreveport, Louisiana. And after graduating, I had basically did traditional psychiatric jobs. Some leadership roles, medical director, IOP, inpatient, outpatient, all the settings of care, using what tools were available for most of these, this 10-year period of just pharmacology. SSRIs, SNRIs, psychotherapy in a traditional sense. Then I opened up my own practice in 2016. It was back then called Advanced Psychiatric Solutions, based out of in a suburb of Chicago. And it was for the purpose of bringing, ketamine treatment to this region of the United States. There were no clinics in the state at that point. And I guess I'll go back to a little bit of how I got into it, but first, just now where we're at is I'm the founder and chief medical officer. We call ourselves Hope Mark Health. I have 5 locations across Chicagoland area and growing. It is at heart, though. Yes, we were the first to really do psychiatric foundation and ketamine clinic, right? Like it's really meant to be for treatment of mental health disorders in that setting. That we were the first to do that, and we've expanded, but we're at heart a psychiatry and behavioral health practice that has multiple service lines. So ketamine is one of the tools that fits in, and we have a lot of experience doing it, and it's one of the things we do a lot of, but it's kind of like we try to say we're not a ketamine clinic, because to me that's a little too singular of one service line, whereas to me this is just another tool in the tool belt. So that's where we're at right now, just leading the 5 clinics, all the medical care across all our locations. When I opened the practice, it was because I wanted to start offering ketamine. And when I opened it, it was the only service line that I did. It was only half my time at most, maybe less. I was chief medical officer for a different company in the addiction space. I was earning my living doing other things, but doing ketamine kind of solo in my clinic to start. As soon as I started treating 2-3 patients with it, I saw how effective it can be. I kind of shifted my focus with time into focusing on the practice. It was originally just ketamine, but then what was happening was I was getting phone calls from patients that were like, I went to another clinic that opened up downtown or somewhere else here, and I'm feeling better, and I'm on this medicine, and I'm seeing my therapist for this type of therapy. And I asked the clinic, what do I do now? Like, what do I do with my meds? What do I do with my therapy? And they would say, ask your psychiatrist. patient would either not have a psychiatrist, or the psychiatrist wasn't very familiar with ketamine, and maybe would say, oh, you're doing better, let's pull off the medicine. Now, maybe you don't need the antidepressant. Or they'll be say, why would you go get that treatment? And it would be a negative reaction. It was a mixed bag. So I realized that I did have a niche here, that I know what to do in that setting specifically. Like, when do we adjust meds? How does it all fit in? I wanted a little more I wanted to get busier in my clinic, so I started taking insurance and started doing psychiatric med management in my practice. And that's when it really dawned on me, as I was getting patients, that that's the niche. Patients should come into a clinic looking for a mental health provider. Then if they're suitable for ketamine, you can take your time and educate them for an appropriate patient for that service line. And then they can utilize that service line, rather than just saying, okay, I'm dependent on trying to go out and just try to find a patient directly for ketamine that I'm not already treating. It didn't feel natural, and it allowed for a very nice kind of pathway and journey for a patient to not have to come in specifically for one service, but then have that option, and they're just coming in looking for mental health care. That's when I said, all right, this is going to integrate with insurances. This is going to become bigger and bigger with time. And that's why I wanted to add more and more service lines. So now the clinics offer TMS. It offers data burst like augmentation with ketamine. It offers Spravato therapy, ketamine assisted therapy, all kind of service lines.
Fantastic. I appreciate you kind of describing your evolution and relationship with this, because it is emerging. And for our listeners, the doctor has already recommended some methods that we have other content on. So I encourage you to look at some of our past episodes talking about some of these more, peripheral methods that can help with symptom improvement. And we're wanting to engage in these conversations. Prior to interview, I was telling Dr. Nazeer that I had a client that was interested in ketamine therapy, and I knew very little about it. And I was in that position of kind of learning alongside the client. And as soon as a person brought it up, I was able to, respond and say, let me do more research, and then did more research, but also would have appreciated if I had that information before that session ever happened. So I'm grateful to Dr. Nazeer for having this conversation today, because I think there is so much we as clinicians don't know about ketamine or even misunderstand. So with that in mind, why don't we start with an explanation? What is ketamine, doctor?
Sure. So ketamine, it's actually on the World Health Organization list of essential medications. So it has a history, and it goes back. It was developed initially as an anesthetic agent in the 1960s, approval kind of in the really early 1970s as a medication used by anesthesiologists primarily for anesthesia. There were some studies also on pain control for it. It's still used to this day in operating rooms and emergency rooms as an anesthetic that can be chosen for a variety of different reasons. But to put in perspective, like if you were a child and you broke a bone, you went to an emergency room, ketamine is one of the likely short conscious sedation kind of approaches that you might get a dose of ketamine 5 to 20 times the amount that what we're using for mental health indications, all is a bolus at once over, let's say, half a minute or a minute, versus over 45 minutes is how we do these low dose. So it's kind of like a microdose approach that we're using now. But ketamine, it's a dissociative anesthetic. It produces this affective dissociation, which is, why it kind of falls under this whole umbrella of altered states of consciousness. Some kind of view it as a stepping stone in the psychedelic medicine realm, because there are some similarities here. That dissociative experience, for some, is an adverse effect. For some, probably about a large majority of patients, it would be a therapeutic benefit to be in that dissociated state. That's why it's so important that we're all educated on how to handle that experience and how to make the most of that. But ketamine started getting some traction with research. I think what really tipped the scales, at least for me, to even clinically want to utilize it for a mental health condition. It really stemmed for some of the National Institute of Mental Health studies that were coming out, like by Dr. Zarate and his team at NIMH, where they had like a landmark study in like 2012 and 2013 timeframe, where it actually showed that here's like 6 treatments over 2 weeks, which kind of became the adopted standard for how we would administer ketamine. It was a short study just to show efficacy in reducing symptoms of depression. And because it had dosing and it had a schedule and it had some framework around it, was kind of the security I needed to go ahead and start offering the treatment, because now I actually have an evidence-backed, I guess, protocol to start this with. Now things have changed. There's many variations, but back then that really helped. And that was observed. That was foundational. There was foundational knowledge there from case reports of patients who have received ketamine for anesthesia and had reported improvements in depression symptoms. And those are just case reports, anecdotal, but that was the foundation of why I even started doing a proof of concept study through the NMH, which has now progressed to many more studies, hundreds of studies on ketamine now showing its efficacy. So it was kind of that building block, and showing how much it can help and how quickly it could help was appealing. So now ketamine is utilized, and it is a dissociative anesthetic, but that is probably not the right way to describe it, because ultimately in the mental health space, and why is this being utilized, all comes down to like one term, and that's really neuroplasticity. And that's kind of where the field is heading. I mean, there's not a lot of drugs in development that are still looking at the old mechanisms of action for antidepressants like SSRIs, SNRIs. They're all looking at things that work on glutamate, GABA, the concept of neuroplasticity, which I know we'll get into more in this. But so we have a new approach to treating the depression. And it's another kind of major element. The neuroplasticity is the endpoint of TMS, psychedelics, ketamine. They all lead to that. And there's a lot of other ways to improve, and increase neuroplasticity, even non-treatment wise, and things like exercise, positive thoughts, and all that. So it's a broad term, but ultimately neuroplasticity is what's behind ketamine. So, and this was the only thing available to us. It was Schedule 3 medication with the DEA. So it's off-label use, but it's available to use. I mean, unlike future things like psychedelics. I mean, those are Schedule 1 and we cannot utilize them unless we're doing research. So having this, ultimately, when we look at risk-benefit analysis of all the treatments we're providing, and I'm looking back at all the decades of looking at antidepressants, SSRIs, SNRIs, TCAs, MAOI inhibitors, all of that, and then comparing the adverse effect profiles, the daily medication approach. It was like the field was first very analytical and focused, on primarily psychoanalytic therapy for some decades, a Freudian kind of phase of it. Then it flipped into this biological mode, and it's all about the monoamine neurotransmitter hypothesis, and the field became into a lot more medication prescribing, dampening symptoms a bit. But we're not getting to the root cause of conflict, both psychologically and medically, many times with those two kind of extremes of the pole. And now I always feel that ketamine brings it back to kind of that intersection between the psychological and the biological basis of depression. So you can reprocess thoughts, reframe trauma, past experiences, but at the same time, we're making an effort to gain neuroplasticity, balance glutamate and GABA. So there's a biological basis of what's happening too. That doesn't mean that that's the cause of depression, exactly what ketamine's addressing, but it's a new way of addressing the symptoms where you're combining it with this added layer of benefit of actually being able to leverage the altered state for your benefit therapeutically.
This is so interesting to me. And I assume it's actually probably the origin of many medications, that something was created to do one thing and then you go, oh, wait, look what happened over there. And then the next thing you know, we have a medication that's being used in a much different way. What's the timeline? Like you had mentioned kind of in the last 10 years, this for me was absolutely not mentioned in my post-bachelor's education in the early 2000s. So you nodded. Tell me kind of like, what's the timeline? When did the research really start to explode onto the scene, and where are we in the research? How much more needs to be done?
And yeah, same here. I didn't know anything really about ketamine until about 2012, when some of those NIMH studies started coming out. And that was kind of like the door opening to this. There were like smaller studies before that. Like there's one from like 2005. There's some, but not enough to gain traction. We're not taught anything about, I didn't get trained on anything about ketamine except for ketamine as an illicit substance when I was in residency training. So it was, I would say about 2012, 2013 is when the foundational like studies came out where there started being some providers across the country starting to offer it. When I opened my practice in 2016, I mean, it's not that long ago. I mean, we're looking at like 7 years ago. And when we opened, we were the second overall in the state. One opened up a few days before us, and it was not a psychiatric based one. And then there was nothing for 2-3 states over. So patients would fly from pretty far and away. Most people had no clue on what I'm talking about when I was bringing up ketamine. That took a lot of education at that point. But since then, it's an explosion of awareness. So now most patients are actually come in very well aware of this. I mean, some are not aware. Some practitioners are still not that familiar, but many are now. I guess I don't feel as much as on an island anymore doing this. I mean, I know like any large city could have anywhere from 10 to 60 clinics already that are offering this treatment. The big change, I think, when FDA approved intranasal esketamine or Spravato in March 2019, that is what I think was the major like tipping point for like a wider adoption by providers to have the service line, because it's not ketamine, but it's still in the same family. And it's FDA approved and it's got insurance coverage for some. So I think that provided acceptance on a broader basis within the mental health treatment community. Whereas I think psychiatrists in general were, rightfully so apprehensive and wary of this new treatment. They needed more evidence to come out and safety to be really validated better. And where there was more adoption, I think, from non-mental health fields, like specialties that were offering this treatment, let's say anesthesia or emergency medicine, they're quicker to adopt it, I think, than the psychiatric community. But that has changed. I would say since 2020, when COVID hit, till now, I mean, if you compare growth in the last 4 years of this arena and how many studies have come out in that time frame and compare it to the 3 years before that, it's probably more than double. I mean, the curve is exponentially going up.
Thank you. I appreciate that. You had mentioned ketamine administration and the approved method. For those of us who are not as familiar with ketamine, as you mentioned, starting as really an anesthetic, which is going to be administered in a different way than we typically would do for mental health treatment. Can you talk about, here's what we used to do, here's what we do? I'm curious, are there any moves to change that? Or is the intranasal method really what's shining and that's where it's staying in terms of mental health care?
Because, all right, ketamine, the most common, well, there's probably the two most common methods of generic racemic ketamine. So this is different now than the patented molecule by Johnson & Johnson or Janssen, and they have an FDA-approved intranasal esketamine. Intranasal esketamine, so that's intranasal spray, still in the clinic. It's all nothing's happening at home. It's monitored. There's a FDA REMS program, risk evaluation mitigation strategy program. So every single patient, we submit data to the FDA's REMS program about it. Every single treatment, every provider across the country, you have to be REMS certified. So it's super regulated and monitored, where they're gathering long-term safety data. There are all sorts of things. That was open the door. But IV ketamine, which was being used before even Spravato was approved, That IV ketamine is still the number one route, I would say, administered. And that reason for that is because it is 100% bioavailable. So everything that I am giving in the IV bag is getting available in the bloodstream and going into the brain, crossing the blood-brain barrier, which allows precision and predictability and individual tailoring of the experience better. Gives me control. I can kind of make it less intense, more intense. I can push a medicine IV to get a better impact if somebody's nauseous or anxious. So that is probably has the most data behind it and the most common route, but it's a hard route to do because it requires full IV function. Like a lot of times you need a nursing staff. Psychiatrists aren't used to having like IV lines in clinics. I mean, that's not anything we've ever really done until ketamine really came to the scene. So there is IM, intramuscular ketamine, that's probably also very heavily utilized, easier to do because it's just a shot. It's an IM shot. Different experience, completely different than IV. Can be a little bit more intense. A lot of people refer to it as a rocket ship because the levels rise to a higher concentration and quicker, and they drop in a different manner too, whereas IV is a lot more smoother and controlled. So, but IM is an easier way to kind of administer it. Then there's intranasal, generic compounded ketamine, which I'm not a huge fan of, to be honest. There's just not enough supporting data behind it. Plus, I'm not a huge supporter of doing any of this really at home, unsupervised, unmonitored. I just don't think we're there yet. This is a powerful medication that should be in a supervised setting and monitored. And we'll go over that later of what are we looking at. But then intranasal ketamine is probably now what, meaning Spravato is one of the most widely used forms now of intranasal that I'm all in favor of because that is in the clinic. So I don't know what route will win out in the long run of it. I think they all have their like places, especially with how you package psychotherapy with it, whether it's a troche or a lozenge versus an intranasal spray versus IM versus IV. All different approaches sometimes from a psychotherapeutic standpoint. But yeah, so I think it's here to stay, I feel, but I think it'll all depend on if FDA will give an approval for IV ketamine on its own, or if there'll be more branded versions of it. I don't know, but I think it'll depend. The route matters a lot with ketamine.
Thank you. I appreciate that. And when the intranasal method was approved by the FDA not that long ago, was that specifically for the treatment of depression?
So the label itself from the FDA, it approved it for treatment-resistant depression in conjunction with an oral antidepressant, and that's how they studied it, meaning both arms had everybody started on an antidepressant in both arms, and one arm it was a placebo nasal spray, and the other arm it was Spravato. So the label means you need to have failed 2 medications of adequate dose and duration, or due to adverse effects. If you fail 2 medications in your depressive episode and you are staying on a medication, an antidepressant, traditional one, and you have major depressive disorder, then Spravato is approved for that indication. But 2020, it got another indication for major depressive disorder with suicidal ideations or behavior. It didn't matter if they were treatment resistant or not, but if they had a major depression and suicidal ideations, then that's another approved indication for Spravato.
Thank you. That's really interesting. So previously it had been quote unquote treatment resistant depression when tied with an antidepressant after at least 2 failures on other oral antidepressants. That's so interesting. And then now if it's depression with thoughts of suicide, then there isn't the requirement for a failure first. And for people who aren't familiar with this idea of a fail first can sometimes be required by insurance companies for a myriad of reasons. Sometimes it's about checks and balances and making sure that there are appropriate interventions considered first before moving to something that may be interpreted as more severe or have different risks. And oftentimes it comes down to payment. I've certainly worked with clients that have to go through the hoops to get approval for certain medications that may be off label, or they have specific FDA approvals, and you need to kind of fall in that in order for them to be covered by insurance. But I want to point out, speaking as your local insurance nerd, this is specifically for the coverage of insurance. So if a doctor wanted to use these treatments without necessarily doing these prior failures of antidepressants, confirm for me, Dr. Nazeer, they could do that. It would just not be necessarily covered by the insurance company if the patient has insurance.
Correct. Yeah, they can still do that, and even if the insurance company is denying, the authorization. In the real world setting, that you won't see that happen with Spravato, intranasal ketamine, because that is a branded medication, and there's a professional component to it that that there's billing for, and then there's the medication, super expensive. None of it makes sense unless you have the insurance coverage. However, on the other side of the coin, anything related to ketamine, generic ketamine, whatever route you're doing, all of that, yes, then that makes more sense. If somebody was not relying on insurance coverage, there is very little insurance coverage for IV ketamine. There are some plans that cover it. I know of a few in the country that cover it for mental health conditions, but majority don't. So, but the price point it's going to be more of access to care and more affordable for a patient to do that.
Just out of curiosity, are you finding that if you as a provider are advocating with like a single case agreement or something like that, when it's not specifically covered in the formulary, do you feel like you're getting any traction, or are other MDs getting any traction with this? Or is it just really commonly denied by insurance companies if it's not explicitly covered?
And we're talking about IV ketamine specifically, or Spravato?
Yeah, any of the above, because I think, as you mentioned, there's often this access issue. And so I think many of us are familiar with kind of playing the game of, well, they won't cover that, but they'll cover this, and here's where this is indicated. And obviously, we as clinicians, as mental health professionals who are not medical providers, we're not making these decisions, but we also may be talking with patients about how they can advocate and what options might be available to them if they want to pursue this and they're just hitting roadblocks with insurance.
Yeah. So when it comes to like actual interactions with an insurance company related to getting approval for Spravato versus I had tried in the beginning many a times to do single case agreements, peer-to-peer exceptions, appeals for IV ketamine for mental health. And the amount of time, I guess took on the practice, and the success rate was almost zero, that eventually we just kind of stopped. It just felt like a futile effort at that point. Even now, we don't necessarily, the assumption is that you're not going to get anywhere because it's investigational still. Like, even though there's so much data behind it now, and it's been in real world use for years now, it's still considered, quote unquote, experimental investigational, and it's really easy for a denial to happen. On Spravato's side, though, that I do spend a lot of time on all the time, speaking with insurance companies and getting agreements and exceptions, and there is a success rate there. I mean, it depends. It's like, I feel roughly, it's like half the time I'm successful, half the time I'm not. And typically, this goes down to things like, well, all right, they use cannabis in the 30 days prior to when you're starting it. Like in the studies, no patient were there was exclusion criteria that you cannot have used cannabis or any substance or have any SUD for that 30 days leading into the study. So sometimes it's not like we're diagnosing any sort of substance use disorder. Maybe it's a medical card for a random other condition that they're getting medical marijuana for, but that might be the reason for denial, and sometimes I can't get it overturned. Or, well, somebody thought they had bipolar disorder in a previous treatment journey with a different practitioner, but in our system, we did our investigation. We don't think it's bipolar, nothing showing any evidence of that, and here's why. But those are probably the two most common kind of like reasons we're on the phone with an insurance company, is those two.
Thank you. I appreciate that background and those exclusion criteria, because we would be remiss to not mention the cost of these things, and that sometimes these are the hoops that providers have to jump through and have to be realistic about what may be possible and also what they're informing a patient about. So thank you kind of for the very quick 101 just on the administration of ketamine. From a practical standpoint, when a patient has learned about it from a family member, let's say, and they go to their therapist and say, I'm interested in ketamine therapy. Then the therapist goes, who should I refer you to? Can you kind of walk me through from that initial mention of the word ketamine through, like, here's what treatment looks like, here's who you refer to, here's who's involved in it, how long it takes, just so that we can kind of have that framework as we continue our conversation?
Sure. So you're right on one thing. That is one of the most common places where the topic comes up is in therapy. That's the first time. So one of the a major referral source for us, probably one of our biggest, is therapist practices, as well as primary care practices and some other psychiatrists. But therapists play a huge role in that, and it's important to kind of know the framework of it at that point. So one thing to know is that yes, there's one route that involves insurance coverage and makes it more affordable. It's a different process altogether when you do Spravato. Time commitment's different. How it all looks is different versus IV. The best place to first start where you're going to refer to, first of all, that should, in my opinion, it really needs to be in a place where there's mental health, specialist involved. So in a setting like, let's say in my clinics, every patient referred to us is going to get a full evaluation and an entire informed consent visit following that, where we go over literally all, not just, this is a big benefit that, hey, okay, we're going to discuss ketamine as an option, but contrast it to TMS, contrast it to Spravato, all of it, and let somebody kind of choose a route that fits them best, because a lot of this is logistics, time commitment, and all of that, cost, all of that matters. So if it's a clinic where there's maybe just no support, because in my opinion, this is not like, okay, this is a kind of a light treatment you just go do. No, it's a big investment. Some patients start the treatment journey knowing or even verbalizing that I've tried everything, nothing ever works. If this doesn't work, then I'm contemplating ending my life. And having that in mind, that this can be a very complex situation, there needs to be a protocol set up in where you're referring to, where they collaborate with the primary therapist or the primary psychiatrist. They have their own mental health specialist, so everybody's speaking the same language, and extremely robust screening and follow-up protocols to it all. Like that, to me, is going to give somebody the best chance of having like not only just a safe experience, but also outcomes can be improved that way. Plus, it makes the entire journey feel more integrated and holistic rather than fragmented, where I have one clinic that I just go get this dose of ketamine, and what do I do now? Like how often? It needs to be all integrated in one whole spot. Typically, a reaction may be from, if this comes up in, let's say, a therapy session, will be, well, ketamine's special K, ketamine's addictive, or it's a recreational drug. And that might be the first kind of thought that pops into somebody's mind. So it's important then to kind of set that larger framework that, okay, there's actually data supporting its efficacy. It's been utilized now for several years. There is an FDA approved product from that family. Things are in development related to this. So meaning that it's not something that we're just doing without any sort of reason or backing. And that when utilized appropriately, it can, there's data supporting its use to treat addiction. I mean, I'm addiction boarded, so I utilize ketamine to treat alcohol use disorder, cocaine use disorder. It helps me get patients tapered off of Xanax or opiates. So there are a lot of ways that it can be leveraged, but that will only work if the treatment team has an awareness of the condition you're treating and is screening and monitoring for it. Now, the therapist will play a role going forward in this. So, when they make a referral, and let's say the patient gets to a treatment center, we get a release of information, we collaborate back. So at this point, there's going to be 2-3 kind of routes. Like if a patient has a therapist they're working with already, and that they're doing, whether it's EMDR, trauma therapy, CBT, doesn't matter, whatever their modality is, that should not go away. So CAP, or ketamine assisted psychotherapy, is a specific form of psychotherapy that we offer in our clinics, but that's not the only kind. So we have patients who do medical model of IV ketamine. I'll talk about that. And then the CAP model. And we kind of choose what makes sense for each patient, especially when there's a lot of trauma to unpack. It might be better to do a CAP approach. That means our own internal therapist who is certified and trained in ketamine assisted psychotherapy or psychedelic assisted therapy. And the focus is about the ketamine experience, what rapport, what's going to come up, intention setting, preparation, integration of, inscribing and integration of what comes up during the treatments. It's structured, it's protocoled, it's time limited. It's typically, like in our practice, about 4 or 5 weeks of a protocol, including 6 dosing sessions. And each dosing session, there's either a prep visit right before the dosing or an integration visit right after. And it's all about ketamine assisting the psychotherapy. Now that can happen, and there can be outside psychotherapy happening as well, and then we all collaborate. Or it could be that the patient doesn't really do the CAP route. They get medical IV ketamine in our clinics. They're still going to see the psychiatrist. We're still going to do all that stuff, but we're not providing CAP connected to those treatments. And then what the route, and this can work too, like every patient's different, is that, okay, because the patient is in a neuroplastic state, there's an increased level of motivation, there's more malleability, less cognitive rigidity. The therapy that they're doing, if they were stuck in therapy, that can become unstuck in a way. Or maybe there's trauma to unpack or a root conflict that the insight level is low, that you're just not getting to it in the therapy. And we'll kind of collaborate to say, okay, now we're starting the treatments in parallel to this. And you'll see that this will maybe improve the abilities to make some progress in the therapy, but it may also help to try to time the therapy that you're doing to be in that 24 hours following the treatments. And if you time it like that, your brain is just generally more malleable. We've had it range from, zoom into our clinic from an outside therapist within the next hour, all the way to the next day, later in the day, and anywhere in between. But as long as it's kind of following, and it's not about what came up in ketamine, because that's a separate certification and training, and they're not altered anymore, right? Ketamine, 85% leaves your body within 3 to 5 hours. I mean, every minute after the treatment, by the time a patient 5-10 minutes later, maybe 15 minutes later, standing up, they're still perceptually a little off, maybe a little unsteady. By the time they're home, most people are quite functional. Can't drive or make big decisions or drink that day or do anything like that. But in general, very functional. But they're no longer feeling those acute dissociative effects. That's why but their brain is being, triggered for neuroplasticity. That cascade of biochemical events of triggering neuroplasticity happens for 5 days after each treatment. So, and then that accumulates over 6 treatments over 2-3 weeks. There's this build and swell of neuroplasticity. So overall therapy becomes more effective in conjunction. So a patient will come in and then pick a route, and then they'll go. We're very structured. We have an entire protocol for each one, how we do the dosing, when we give visits in between where they're not worrying about dosing and they're just having a check-in with us to talk about it in more detail medically and what we want to do with the infusion experience to fine-tune it all. And then a review and planning. We're monitoring outcomes. We're doing tox screen, everything that surrounds it. We even baseline test for cognition before going in, because ketamine can, if you use too much ketamine, it could negatively impact cognition. So we always get a baseline screener as they start. So we have a comparator. So the treatment center should really be able to handle all of that, but the release of information, collaborations going on in parallel. And sometimes it'll be something's coming up now in my therapy, and they need to collaborate with us what are we seeing, and is ketamine related to this or something? And those are things that we we want to be able to do. That'll give the patient has rapport with their existing therapist and trust. So the main thing is that the referral is the therapist needs to really trust where they're referring their client to and have that relationship.
That was so helpful, the picture that you just painted about how treatment really unfolds. So it sounds like the average protocol as 4 to 5, maybe 6 weeks, as you mentioned, kind of the 5-day neuroplasticity after infusions. Is that right? Like that when people think, okay, I'm going to do ketamine, we're looking at a month to a month and a half of an initial treatment episode.
Yeah, I mean, usually, so the protocols always used to be for regular medical model of IV ketamine to do 6 infusions over 2 weeks. And everybody's kind of rigid because that's kind of how it all started. I think with time, there's been enough, proof of concept and outcome data that if you did 6 treatments in 3 weeks, the results can be quite similar. And there's a logistical aspect to this. You got to plan time off and you need a ride home. So there's a lot to it. So I think in our clinic, a lot of patients most are actually choosing to do it 2 per week for 3 weeks. Now that's the medical model. And there's an eval visit, an informed consent visit, a review and planning, a midpoint. There's stuff surrounding it. The whole thing gets done within a month. The CAP model though goes about 5 weeks. So they're doing 2 per week, but then there's a week in the front and a week at the back where there's kind of like, putting it all together. There's a rapport building in the front, preparation. There's integration and scribing at the end. So expect 4 to 5 weeks at the most for the initial series. That doesn't end there. It's important to know there's like a maintenance part to this we'll get into. But in general, if that induction period, there's neuroplasticity happening, right? For I said 5 days, it's like fixing potholes on a highway. There's pruning of nerve, like transmission channels, receptor channels when you're depressed or anxious. And it's like losing the fluff of like a bush and it's turning into just the thorns. And you're trying to trigger it to kind of build all those extra tentacles and pathways. That's happening because of BDNF, brain-derived neurotropic factor, which in my analogy is just like a foreman on a blowhorn calling a construction crew to fix the potholes. But if you do 1 infusion and stop, will it just change your life and fix anything? No, probably not. I mean, it can be transformational, but you only fix a couple potholes. There was no there's not the whole construction crew there. And there's maybe some benefit, maybe not, and it'll wear off quicker, and you would end up needing more in the long run. Our ultimate goal is the least amount of ketamine to keep somebody well. So that's the concept of why you do 6, is because now you're piggybacking them, and the previous cascade of neuroplasticity, now you're having a new foundation with the next one. It's actually infusion 3 or 4, somewhere in the middle of the course, where most people start feeling benefits. But there are some patients who get delayed benefits. I've seen as late as after the 6th treatment, and before that, they didn't think it was working. And then there are patients where the very first one is life-changing and it's miraculous. So there's such a wide range, but that's the key, is managing expectations, that it won't be an overnight fix, but you are basing it on a higher efficacy ranging between 65 and 80%, depending on the study, of how many people achieve remission or full response, whereas traditional medications are around 30% when you look at like the STAR-D trial. So for that reason, it's like, hey, you're getting the best chance of success, but don't expect it to be overnight. Manage the expectations. And then the more you do with the neuroplastic benefits you're getting, the better off you'll be to need less of it going forward. That's key. If you do nothing, you don't do therapy, you don't make lifestyle changes, you don't get to the bottom of the trauma, any of that, you might feel better, but you're going to need a lot more ketamine frequency to stay well. And ultimately, you'll not really get the tools in your tool belt to handle the stressors coming your way. Whereas if you do the work in the context of ketamine happening in the background and helping, and this is the medical model, it's not all about just ketamine assisted psychotherapy. It's even just if they're getting that neuroplastic benefit, then you're going to have a better chance. We have a whole way we discuss when we go back to looking at what their other treatments are. Like we pause everything, like no med changes right now, none of that. Let's just put a hold on everything, get through the treatments, find out that it works first. Now, let's say it works. Now, and this is important, that patients don't come in assuming that I'm going to put a lot of money down for this treatment and this is a one and done deal, that after the end of this, I won't need any more treatment. I'll get off all my meds. Now, sometimes, yes, but most of the time people will stay on medications, and we have a strategy of how we approach that. But the main thing is that you're going to first decide that it works and all that. Next is like what we call it the optimization phase, and that it's maintenance. But if it works, now you want to find out how long the benefits will last you. If a clinic just says you're going to come in every 2 weeks, you're just going to automatically you come in monthly, and like there's no variability. That means they're kind of putting everybody in the same bucket, and it's not the reality. The reality is every person's maintenance interval, that's the term we're always using. That's the frequency, how much you got to come in for your treatments, maintain on to stay well. How long does the benefits last you? That varies. I have some patients who come once every 9 to 12 months, and they'll do 1 or 2 treatments. They're good all year. And then there's patients that it never gets beyond a couple weeks at the most. And our average in our clinic is actually every 6.5 weeks. So we can get most people past the 1 month mark. Many patients will make it 2-3 months. But let's say you have to build up to that. So the next 6 treatments, there's 2 ways we usually do that. One is we're usually saying, hey, let's do a structured approach to this. Come in 2 weeks, treatment, even if you're still doing okay. Then you go 3 weeks to your next one, then 4 weeks to the one after that, 5 weeks. We're adding a week each time. One of those times they might come in and say, I felt like I needed to come in earlier. There's no trigger, is wearing off the benefits. Then we don't add another week. We try again at that same interval. And if same thing happens, now we've identified their interval. That allows people to be very clear on how they're approaching this. The other way, which was the more common way initially, was just, okay, when you feel you need it, come in. And then come in quickly. Don't wait weeks and weeks after the benefits wear off. Then you're falling behind. You actually end up needing a couple, 2, 3 to kind of regain those benefits. But if you catch it in that first week and that something's changing, you come back, you do 1, it's a reset button. And now you're going to go longer and longer each time. And sometimes people might jump from 2 weeks it lasted. Usually the first interval is the smallest. And then they're at 3 months suddenly. So there's less money out of pocket, less time commitment. But they're waiting for the other shoe to drop. They're like waiting to feel bad. When do I come in? When's the actual time that should mean like it's more nebulous. It's kind of a gray zone, and it's hard to just suddenly plan in a treatment when you feel the benefits wearing off. So I think more patients actually like that structured approach. And once you figured out the interval, now you're on maintenance mode, maintaining. But if that interval is short, this is a key that people don't view with ketamine as like you just do it and you're done. It's like you figured out your interval. What if it's every 3 months and you're on 2-3 medications and doing therapy? Therapy should stay no matter what. But the medications, maybe you're on a couple meds. We want to try to go one by one and get them down at that point. And if that means you're coming in every 2 months or 1 month instead of every 3 months, that's flagging us to know that this is not worth it. We might want to just stay on the meds and do genetic testing, optimize them.
Thank you. That was so helpful. For you as a psychiatrist who has a specialization in ketamine, do you generally take over care from another psychiatrist when a patient comes to your clinic, or are you often collaborating with them at the same time?
Both. Yeah, obviously we're equipped to take on all the psychiatric care. So it all depends. If the patient has a psychiatrist that they are planning to stay with, I mean, there's, especially when they're involved in that referral, like then even if a patient wants to switch their care to us for that part, we really encourage them not to, and we prefer to collaborate with them. And just really we will handle dosing adjustments for meds related to the ketamine itself about the actual infusions. There are certain meds we might say, you know what, hold that med before infusion, things like that. But the major med changes, we want no major changes right away. But then we're collaborating with them through it all. And as patients are in maintenance mode and now it's time for that, then we kind of want to help collaborate. But if a patient comes in, doesn't have a psychiatrist, super common, they find us just for this treatment and they're kind of burnt out with mental health care and they don't have anybody established, then we are going to become their primary providers. Yeah.
Thank you. I appreciate that. I am going to make an assumption here that when we're talking about the use of ketamine to manage various mental health symptoms, we're talking about adults, age of majority, people over the age of 18. Is that right?
Majority, but the youngest aged patient that I've ever actually infused was 11. Not that that's common. It was them asking me after spending $200,000-$300,000 and going a million different treatment routes all over the country and nothing working. Me still holding back for 2 years. So like, there's no data really to show this. Eventually after I tried everything in my power to try nothing worked. Then I did it, and it was an amazing turnaround. And that patient comes up once or twice a year and has been doing amazing ever since. Children actually in theory are, handle the dissociation better. They're magical thinkers, less likely to get an anxiety reaction from that altered state is what we've kind of noticed. And their brains are already quite neuroplastic in a way. So it kind of helps in that part of it. But those are one-offs. We are pretty comfortable going down to 17 years old, 16-year-old case by case basis. Below that are more extreme cases. So, there are studies I know that are underway having, looking at adolescent population, but and then my oldest was 92, I think. So we have a lot of patients above 65 too.
Interesting. Thank you. I appreciate you addressing both sides of that. You had mentioned addiction potential and kind of the knee jerk around, hold on, this is a drug that can be used in an illicit manner and can be really dangerous. You also mentioned that you have used ketamine treatments for people who have cocaine, so a stimulant use disorder. You also mentioned alcohol use. Tell me kind of what is the ideal ketamine patient and what knocks somebody out of the running?
So in an outpatient setting with our, I guess, capacity and what we can handle in that setting, if a patient's, well, one is if they're very active in their substance use disorder, and have low, like when you're looking at stages of change, they're like, just low on that, spectrum, pre-contemplation, whatever it might be. And they're just not, their insight level's not there. Those are not going to be good candidates for this. You need to have that motivation towards what the goal is going to be for treatment. And then it can make sense, especially if there's such a high comorbidity of substance use disorders with trauma and mental health conditions. And when that is the case, it's not like a purely substance use disorder with no comorbidity, then ketamine this will rule you out for things like Spravato, because there's approved indications, and that this would exclude you, but IV ketamine can be used for that. For those indications, if they are motivated for change, sometimes it's an incidental issue. Like I drink, it's no alcohol use disorder, but I'm treating depression or PTSD. And then I don't want to drink much, my craving. Even though there wasn't ever an identified issue at all. And they're just saying, what's going on? I don't feel like drinking. That sometimes happens. But when we have patients that actually have an active SUD, they're motivated for change, especially when they have a comorbidity. Those can be candidates, but that type of utilization of ketamine is trickier and more nuanced. And even in my own system of my clinics, really those would be kind of the cases that maybe anybody in my system who's addiction focused and specialized would try to do, because it's a whole different way. You're doing more frequent touch points, and you're doing more tox screening, and you're understanding harm reduction and safety medically. So there's a lot more that goes to it. We never infuse anybody who shows up intoxicated on anything. However, somebody might have a slip in between. What does that mean? Can we proceed with treatment the next day or not? In general, the most common SUD that I tend to use ketamine for, and I find the most success with, is actually sedative use, meaning people on alprazolam or other benzos, a lot of times prescribed, sometimes illicit, high doses, that getting off has always been almost impossible. And we have a method of how we kind of do our tapering. And every month when they drop their dose 10%, they're coming in for a treatment the next day to help slide down to that next dose. There's an initial induction of ketamine where we make a little bigger change in reduction of their, so it's all a way to assist that whole tapering process. Or with opiates, same concept. That's actually where I think I find probably the most success.
Thank you. I appreciate that. I have a background in the addiction field, and for listeners who aren't as familiar, the withdrawals from benzodiazepines are notoriously awful, and people want to crawl out of their skin. And I appreciate you making that point, because I think that is one of the things. Goodness knows, getting off any substance can be very difficult, but there are some that are particularly known for causing so much pain and just discomfort. So thank you for addressing that specifically. When it comes to mental health conditions, like I'm thinking of bipolar disorders, psychotic disorders, dissociative disorders. Do those things respond well to ketamine? At what point does the existence of one of those conditions make you go, no, we shouldn't do this? This is not the right treatment for this person?
So it's actually, to simplify it, actually it helps to look at when is it that we absolutely don't want to move forward with it? Because outside of what I'm about to say next, from a psychiatric standpoint, there's very little absolute contraindications. The only time is when you're actively in a manic or mixed state. So not the concept of bipolar disorder, it's bipolar in one of those phases. If they're bipolar in a depressed pole or phase and there's no mixed or manic symptoms, then we're fine. We do it all the time. We've treated many, many patients with it, and it works. Like, I haven't found any kind of change in like outcomes. The only difference is, hey, maybe we're adding like a YMRS, a Young Mania Rating Scale, to their traditional outcome measurements on a routine basis to keep trying to identify if somebody's heading into the manic side. If somebody gets manic, maybe you just pause the treatment for a while, do what you need to do to control the mania, and the next time they're in a depressed pole again, we can go back to it and start leveraging it again. That's kind of how we approach the bipolar. Schizophrenia or any psychotic disorder, from a theoretical standpoint, would be a contraindication. If you're acutely psychotic, as ketamine can amplify not only mania but also psychosis. That is more in theory. There is also some counter theory that there's a paradoxical reaction that can happen, but the problem is, like, meaning that you can still deliver it safely in that population if there's enough need to do it. It's never been studied. That's the problem. It's an ethical dilemma in researching something that could make you psychotic in a psychotic population. I had one patient who has full-blown schizoaffective disorder, but the suicidal ideations were so strong and the benefits of ketamine were so clear that we still did it, and it never made the psychosis worse. So that gave me a little comfort in it. But those are the only two scenarios. Actually, the third is ketamine use disorder. If that is actually identified, that they're coming in and they have this illicit ketamine history or overuse history, I wouldn't leverage ketamine to help treat that and get them off that. I don't do that, because you just not in an outpatient setting, you don't have enough control over the variables that they can still use ketamine outside of the clinic. So that would be the only other contraindication. There's 2-3 medical reasons, like intracranial aneurysm, intracranial hemorrhage history, things like that. There's a few more, but very few even physical contraindications. So generally speaking, most people can get it even with an SUD present that's dual diagnosis, as long as, like, we're screening and monitoring for it and part of the treatment plan.
Thank you. And for our listeners, SUD refers to substance use disorder. That's really interesting what you shared about people who have a ketamine abuse history. Do you include all hallucinogens in that, or is it specifically people who this is their substance of choice, not like a class of substances?
So I typically will kind of limit that to mostly ketamine use disorder. With other hallucinogens, the only time it really would give me pause, because most of the time, let's say it's LSD or psilocybin or something like that, it's typically the history, if I'm getting that they've tried it several times or they've used it. Like, I'm not at the point of calling it a use disorder per se at that point. It's not necessarily an active problem. I'll let that go, but I'll monitor more closely. But if they have like persistent hallucinations, that resulted from their psychedelic use in the past, or any kind of legal implication, any functioning impairment, anything like that, from that use, then I'm going to include it as well. So it's a little more nuanced with the psychedelic use history.
Thank you. The last question that I'd like to ask you before we end our time together today, we've talked about some of the benefits and how successful ketamine can be for particular populations. Tell me a little bit more about the risks and the drawbacks. Like you had mentioned, anxiety, the sensation of being out of control. Many of us don't like that feeling. So, can you speak to like when things don't go right? What does that look like, both medically and psychologically?
Sure, and that's a great question. That's super important in this discussion. And it all, again, speaks to a center having the ability to like treat within their specialty and scope and handle something like an emergent panic reaction. So in the actual infusion itself, the dissociative experience, typically there's a few buckets of reaction that people will fall into, ranging from, I feel a little light and floaty, nothing transformational, okay, kind of relaxing, to a little more abstract. I felt I was a cloud, I was space, I was an ocean. There's a deeper connection, a deeper meaning, but it's not a pure dissociative episode. Again, this is also typically egosyntonic of an experience, meaning the patients feel like it was a positive experience. Then there's the next bucket where more purely dissociative, where you really feel out of body and you're looking at yourself from a new vantage point, a new perspective. Now, that is still a positive reaction for most. And in fact, that bucket can be the most therapeutically beneficial, especially if I've heard many times from patients, I felt like I did, 4 months of trauma therapy in 45 minutes. Like I looked at it, I didn't have any associated negative emotion, and I looked at it clearly from a new perspective. I took the claws out of that traumatic memory and experience. Or the ego, death, and rebirth concept. I'm looking at myself, my identity, my role, and I'm not who I thought I was when it comes to depression. So that can happen, but we're also now closer to the fourth bucket, and that's the negative reaction. And this is that, I guess, I hate using this term, but there's no real medical, I guess, or psychotherapeutic term for it. And when somebody uses the word K-hole, it's like this brink of consciousness and unconsciousness, and it's not comfortable. I'm falling. It's dark. Can I move? Am I alive? Or trauma coming up and they're not ready for it. They weren't prepped. So when that happens, how we mitigate the risk is all the prep that goes in beforehand. Like, if this comes up, here's what to do. We have a lever you can pull in case of emergency. I mean, I can give you an IV push of Versed or lorazepam. It'll calm you down in 10 seconds. Just knowing that's there, reminding yourself that every minute after infusion, the feeling will go away, and then trying to promote intention setting as well as looking at how they're doing their actual infusion experience. So this we call set and setting concept. So mindset going in, we prep them on that, what to listen to during the infusion, what to do during the infusion. All that helps. And then the biggest advice ever it's like lean in, like you said, it's hard to do this, but lean into it and surrender to it and let it take you where it takes you. If the more you can do that, or at least get rid of the negativity and at least make a blank slate and not be optimistic, not be pessimistic, just go in neutral and willing to know that you're safe. And, all of that matters. So if somebody doesn't do all that prep work and when they're administering ketamine and just say, here you go, the odds are much higher they're going to have a panic reaction, catastrophic thinking, what's happening? I can't control my thoughts. So, and then it just feeds into that expansion into a full-blown panic attack. Now, the other things are physical, like nausea. We prep them. We don't eat or drink a few hours before coming in. We give them, medications like ondansetron when they come in. Usually we can get around that. Monitoring that can once in a while be tough, but we have enough ways to address it. Heart rate and blood pressure, there's a reason why everybody goes on about it's not just the dissociation aspect where I'm so kind of verbal about it being done by mental health specialists in a controlled setting. It's because the blood pressure and heart rate also go up, and we're monitoring that real time. We have protocols for if it does go up once in a blue moon, we might need to get better control on blood pressure before doing it. Things like that. I mean, and the rest of what happens in the infusion day, generally is all minor and handles and everything by the time they're leaving is good. Long term, we don't want people using too frequently and leaning on it too much. Then you can have other long-term issues, bladder issues, bladder toxicity, cognitive issues, psychological dependence are the big three.
Thank you. This conversation has been so interesting and eye-opening for me. I have a question that it may appear kind of random. I have seen that therapists and nurses and doctors have been offered opportunities to go on like psychedelic assisted retreats in order to try psychedelics before or in conjunction with treating a client or clients so that they understand what that experience is like. Is that done with ketamine?
It is, yes. That is like some of the approaches for some of the training programs, I think, do offer an experiential element to the training. Obviously, I guess there's a lot you can talk about there in terms of legality and ethics, all of that. I will, to boil that point, like the theory behind it is very sound in a way to me, because ultimately, like, you have to approach a client very differently in the context of them being administered this dose. Is a complete, the way I build our clinics is different. The way the staff trains is different. Knowing how much stimuli to provide and not provide, how to unpack anything that might come up. All of that is and that's all stuff that if you've experienced it, you're going to have an astute understanding of it. But would I say that it's a requirement for you to be able to do this line of work? No, because I know I've seen in my own eyes. I have plenty of staff across 5 clinics who have not experienced it, but understand it and approach it well. I think the pathway, as long as it's legal and ethically sound and that's offered, I think it is a good kind of concept, because it will open your eyes a lot to like, well, how am I going to be around this patient? What are they going through? It matters. Until you truly understand it, you may minimize the importance of it.
Thank you. I was just curious because I've seen that around other types of care, come into our clinic, do some brain spotting before you refer a client to it. Like I've seen that with these kind of peripheral options that we have. And so thank you for answering that question. I was just curious. For people who want to learn more about ketamine as a mental health treatment or as an adjunct in integrated care, what's the best way to do that?
So, you could get on Google and start Googling this, but I always caution people that there's multiple rabbit holes that can take you down misinformation. So like the best in my approach as a starting point could be going where it's an actual reputable association. So something like American Society of Ketamine Physicians, Practitioners, Psychotherapists, ASKP3 is what the association's called. That society. And that's the largest, I think, focused on ketamine, specifically for both mental health and pain for practitioners, but they have a lot of information on there as well. I think that can be found useful for even patients. The other could be something like, Psychedelic Medicine Association. It's a newer association focused more on psychedelics, but ketamine is lumped into there, especially on the practitioner side for these two organizations. Otherwise, I think it's important to just try to stick with very reputable kind of organizations and academic institutions, maybe more so than just like a random, let's say, blog or opinion piece or something.
Absolutely. Thank you. This has been so helpful and comprehensive. Again, for our listeners, Dr. Abid Nazeer, and for people who want to learn more about you and your work, what is the best way to do that, doctor?
I think going to probably our website, hopemark.com or hopemarkhealth.com is the website for my clinics, and it has all the information about all our service lines and what we do. You can obviously find me on LinkedIn or just Google me in different arenas like that. I'm pretty active in speaking and educating and getting out there and trying to really kind of like further this area and field. So you'll probably find some things online to look at that go even deeper. And we went deep today, but even deeper than this. So.
Fantastic. Thank you again for your time. I sincerely appreciate it.
Thank you. I appreciate being here.
You've just finished listening to another exclusive Continuing Ed podcast by Clearly Clinical. If you like what you just heard and you need Continuing Ed credits, please visit us at clearlyclinical.com to check out our 1-year membership, where you'll have access to our growing library of continuing ed podcast courses. Clearly Clinical, where our goal is to help you learn, grow, and shine.